Thank you for the opportunity to present. I have nothing to disclose. Trauma remains the #1 cause of morbidity and mortality in the pediatric population. While not the leading cause of death, abdominal trauma remains quite common. Solid organ injury is the most common form of abdominal trauma, and non-operative management has by and large become the standard of care in children. Fortunately, in hemodynamically stable patients, failure of non-operative management is uncommon and reported to be as low as 5% in designated level 1 trauma centers. In addition to these patients, there is a subset of children with abdominal trauma that do not have solid organ injury where surgical intervention is warranted. The use of laparoscopy in pediatric surgery has grown tremendously over the last several decades. It is proven across the board to be both safe and effective. Over time, this has been facilitated by the development of smaller instruments and equipment, and at this point, it is utilized in every subset of pediatric surgery. Today, I will focus on the role of minimally invasive surgery in pediatric trauma, and specifically, the use of laparoscopy in children who suffer abdominal trauma. And here are just a few examples of what we can achieve laparoscopically in children with abdominal trauma. These images come from a paper I will discuss in the upcoming slides by Evans et al. But you can see how laparoscopy can be used to repair a variety of injuries, including an injury to the stomach, bladder, or rectum. I will focus my talk today and try to answer the aforementioned question by turning to recent literature on this topic. The first paper I will discuss was published in the European Journal of Pediatric Surgery in 2016 from the group at CHOP. This is a single-center report of the use of MIS in pediatric abdominal surgery at a large level 1 pediatric trauma center. The authors aim to describe the use of laparoscopy in both diagnosis and treatment of abdominal injuries and identify the proper role of laparoscopy in pediatric abdominal trauma. They describe 119 patients who underwent abdominal exploration. Patients requiring surgery were predominantly male who sustained blunt trauma. Within the 119 patients, 3 were solid organ injuries that required an operation, which represented almost 5% of solid organ injury. 81 of these underwent laparotomy and 38 underwent laparoscopy. Table 1 further demonstrates these two groups, the laparotomy versus laparoscopy groups. Age, gender, and injury mechanism was not different between the two groups. Injury severity score was higher and GCS was lower in the laparotomy group, likely reflecting an overall sicker population that may not have been ideal candidates for laparoscopy. The laparotomy group also had longer length of stay, both overall and in the ICU. This table further depicts details of all of the operative patients, and again, 38 patients underwent laparoscopy. Over a third of these patients were without any injury found. Almost a quarter of these patients, an injury was identified, but no further surgical intervention was needed, such as a mesenteric hematoma. In another quarter of these patients, an injury was identified and repaired laparoscopically. And in almost 20%, the laparoscopy was converted to a laparotomy. One conversion was for a combination of bowel and bladder perforation, and the remaining 6 were for bowel injuries requiring resection and anastomosis and/or mesenteric injuries requiring further evaluation. And 2 of these 6 only had a limited laparotomy to perform an anastomosis. Importantly, there were no missed injuries or complications with laparoscopy, and there were no complications with laparotomy. The authors identify 7 of the 81 laparotomy patients in which case laparotomy could have been avoided. 2 negative laparotomies and 5 non-therapeutic laparotomies, all of which were hemodynamically stable. Of note, 5 of these 7 were performed prior to 2006 when less laparoscopy was utilized. And it is also possible that some of the 71 therapeutic laparotomies could have benefited from laparoscopy only. The authors recommend laparoscopy in trauma as a take-the-middle strategy. In the setting of diagnostic uncertainty, laparoscopy can minimize the risks and costs of laparotomy, such as money, morbidity, and time, and can be both efficient and effective in diagnostics and therapeutics. These authors conclude that MIS in trauma can again resolve diagnostic uncertainty in hemodynamically stable patients with minimal or no solid organ injury with a concerning exam or inconclusive imaging. It is sensitive in diagnosing injuries and can allow for definitive repair. And furthermore, MIS may prevent laparotomy without increasing the risk of missed injury. The next paper was published in the Journal of Pediatric Surgery in 2019 by a group at Vanderbilt. They looked at the use of laparoscopy in pediatric trauma by looking not only at their own institutional trauma registry, but also looking at the National Trauma Database. The institutional and NTDB cohorts were relatively similar with slight differences in gender and race. The institutional cohort included a higher proportion of patients presenting with blunt trauma with a higher injury severity score than the NTDB. Laparoscopy was used more in the institutional cohort with 16% laparoscopy, 73% of which were therapeutic, versus 12% laparoscopy in the NTDB cases, 64% of which were therapeutic. 81% of the entire cohort had preoperative CT scans. Indications for operative intervention after imaging are listed here and include evidence of intra-abdominal injury, free fluid, free air, and evolving clinical concerns. The most common procedures performed were intestinal repair and splenectomy or splenorrhaphy. And small bowel repair, splenectomy, splenorrhaphy, and hepatoscopy were all more likely to be performed in the open technique. 24 cases were converted to open, and the most common reason for conversion was to repair injuries more easily fixed with exploratory laparotomy, followed by poor visualization with MIS. In multivariable analysis of both cohorts, MIS was more likely to be performed in younger female patients sustaining blunt injury that seemed to be more stable, with lower injury severity scores in the institutional cohort and improved vital signs in the NTDB cohort. When looking at outcomes by operative approach, both cohorts demonstrated decreased length of stay, ICU days, ventilator days, hospital complications, and decreased mortality and decreased complications. Decreased complications remain significant after an adjusted analysis. The authors conclude laparoscopy is safe and efficacious in appropriately selected patients, more frequently performed in female, younger, more stable patients, and can offer a similar or even improved outcome. The next paper is from the group at Buffalo, published in 2019 in the Journal of Laparoendoscopic and Advanced Surgical Techniques. They aim to examine utilization rates and factors associated with the use of MIS in pediatric trauma patients, as well as evaluate surgical outcomes. They performed a retrospective study of the ACS Pediatric TQIP database from 2014 and 2015. They excluded any patient with an absolute or relative contraindication to MIS, which included hemodynamic instability, and relative contraindications including GCS less than 14, injury severity score greater than or equal to 16, a comorbidity of CHF, or a diagnosis code of traumatic shock, compartment syndrome, peritonitis, or abdominal rigidity. 332 patients underwent exploratory laparotomy, and 160 patients underwent laparoscopy. And of note, there was an approximately 30% conversion rate. This is their table 1, and on univariable analysis, there was no difference between the type of procedure performed and age, gender, race, hospital type, payer, or hospital academic status, nor the mean injury severity score. However, there was an association between the procedure type and the mechanism of injury, as well as the region of the United States. They showed a larger number of patients undergoing laparoscopy had blunt injury, rather than those with firearm injuries who underwent more exploratory laparotomy. And MIS was found to be utilized highest in the Northeast and West and lower in the South. When looking at surgical outcomes, length of stay was 2.5 days shorter in the MIS group than the open group, and MIS patients had 1 day less in the ICU. While the authors note a trend of lower odds of having any complication in the MIS group, this did not reach statistical significance. The authors state that the overall utilization of MIS is approximately 30%, signifying that approximately 70% of patients who were potentially candidates for laparoscopy had an initial open procedure instead, as none of these patients had any contraindications to minimally invasive surgery. They therefore feel that MIS is underutilized in pediatric trauma, and as MIS is quickly becoming the standard approach for many procedures, these techniques should be incorporated into trauma training programs, as well as the creation of future protocols for the management of abdominal injuries in hemodynamically stable pediatric trauma patients. In an effort to summarize all that was discussed, I mentioned this paper from 2017 from Emory, who reviewed the use of MIS in children for trauma and proposed management algorithms. They provide indications for laparoscopy in pediatric blunt and penetrating trauma, and they include penetrating abdominal trauma, suspected diaphragmatic injury, thoracoabdominal trauma, suspected hollow viscous injury, and worsening abdominal exam. And contraindications include hemodynamic instability with relative contraindications listed here. Here are the proposed management algorithms for both blunt and penetrating trauma, which both include the use of laparoscopy highlighted here. While all of these papers demonstrate some differences in technique and results, it is clear that there is a role for MIS in the pediatric trauma patient who sustains abdominal trauma in the appropriate setting without any contraindications. Thank you again for the opportunity to present, and I welcome any questions to the email address provided here.